Hi, good evening. Thank you for joining us this evening. This is your favorite show, Ask Dr. Sawh. Wherever you're joining us from, we really appreciate your viewership. This evening, this is your favorite show, Ask Dr. Sawh. Wherever you're this is when we make little mistakes when I didn't not taking the audio off. Excited to do this with you tonight. This evening we are talking about lower back pain, and I myself is a case study. I didn't have to do any research on this one because I have so many issues with my lower back. Going back to a number of years. So tonight I'm going to be asking Doc about my issues also. Before I bring in Dr. Sawdust, let me say that this evening we are not probably going to go until the full hour. So getting your questions early, we're going to probably stop somewhere between 30 to 40 minutes this evening because there is some things that needs to be attended to that will take up some time also. Doc, thanks again for being here tonight. How are you doing?
I'm fine, thank you. And you?
Yeah, wonderful, man.
Happy to be here again, indeed.
Right. So tonight you're talking about lower back pain. The ironic, I don't know if to use the word ironic here, but the ironic thing about it is that I came to your office last week, 2 weeks ago, for the exact problem.
Indeed, yeah.
And I have been suffering from lower back pain. I think I think this problem started somewhere in 2016, and since then I've had an issue. It has really hampered me in many ways. Sure. It's very painful sometimes. Sometimes just getting off the bed in the mornings could be such an issue. I've finally gone on some medication that you have prescribed. There is some relief, a little bit of a relief. I have to confess that I'm not taking the medication as prescribed because it makes me drowsy, and I have to be out on the road. And believe me, you're never gonna be drowsy for people running on this road.
So that's something we'll talk about as well.
Yeah, so great. So lower back pain, man. Let's do this.
Yeah, I mean, I thought it's a good topic to dwell on. It's a very, very common condition. I mean, I always joke that if I were gonna prophesize and be like have a crystal ball about people, so if I want to convince you that I know a little bit about you by reaching you for the first time, I can say to you, Akash, you suffer with back pain. You may say, no, I don't suffer with pain, but I'll say then, okay, you've had back pain in the past, and I'll be 99.9% correct, because it just goes to show that everyone at some point or the other will suffer with back pain.
Yes.
But chronic back pain, where it becomes a medical issue whereby you want to seek medical intervention, it affects about 50% of the population at some point in time.
Yeah.
So at some point in time, half the people will get back pain and symptoms that they want to see a doctor. I mean, I don't know the data if they all will see a doctor, but it is to that extent that it warrants seeing a doctor. But let's break it down, and that's why I feel it is an important thing. And there are serious causes and there are non-serious causes, and there are things that we can do to alleviate or to get into it.
Yeah, let me just say this. Somebody asked earlier if just now if the phone lines are open. Yes, it's open. You can call. You can call. The numbers are up there. 231-2982, 610-1066, and 652-1314. You can call in on those numbers. Yes, Doc.
Yes. So when we talk about back pain, we got to define. So we want to dwell a little bit about lower back pain because, as you know, the back moves. We talk about the spine generally when we talk about the back, and that goes from the neck down to all the way to this what we call the buttocks area.
Right. Well, that's where on the right side
so
is where I get.
We will consider that area as your back, but we divide back pain into upper back pain and lower back pain generally. And the reason why you have what we call mid back pain, which we call thoracic pain, but the two most commonly affected areas of the spine would be the mobile areas. Now your neck is mobile,
right, yes,
and your lower back is mobile. The middle of your back is protected by your ribs. So it adds some stability.
Yes,
so when you get problems, your disc slipping, it tends to occur more either the neck or the lower back. And that is why patients have frequent complaints of the neck and the lower back. But let me just go through a little bit about anatomy, that is, the makeup. So when we look at back pains of the back, I would say to people, I just want to break it down in simple terms so people understand it a little bit clearer. So you've got a back. What a back is made up of? You have a spine, so you have a bony structure. And then you have muscles holding up the back.
Right.
And those muscles are important to keep us erect. And then in between the spine, at the back of it, you have a canal, and that's where the nerve comes down. So that's nerve, you have muscle, and you have the bone. And in between each bone, I will show you the anatomy in a while, you have what we call cushion, cervical disc. So the cervical disc is like a cushion. It's a fibrous cushion with some jelly-like substance, and it works as a cushion for the two bones. So you have the two discs, and in between you have that cushion. Now, when you have trouble, back pains generally, it can come from any part of those, any organ, any of those structures. So it can come from the muscle, it can come from the bone, it can come from the intervertebral disc, it can come from the nerve. So we need to take some history to understand a little bit about it, where it's coming from. Now, by and large, the most common cause would be what we call mechanical back pain. And mechanical back pain is what we call wear and tear. The most common cause of mechanical back pain is wear and tear of the back. So as you know, the back, we stand erect, there's lots of pressure in the back, pressure in the muscles, and over time, like all our joints, especially the joints that are on the high impact joints, your knees, your hips, your back, they're under pressure, you will have some degree of wear and tear. And a common word that is used for that is spondylosis. Have you heard of that?
No. Never heard of that.
So, okay, so it's a term, spondylosis of the back. So you got cervical spondylosis, lumbar spondylosis. In English, in general terms, I mean in simple terms, it's degeneration of the spine.
Okay.
Wear and tear of the back. Now, the reason why I feel that we need to talk a little bit more, dwell a bit more on back pain is because it is so common, and most of us are worried, and we end up having interventions where we present to the doctor multiple times. They say back pain is the leading cause of days off work, and it costs the economy millions, if not billions, in the Western world.
Wow. Yeah.
Just to compensate people for being away from work and what it costs the economy generally.
That's the economic impact of back pain.
Exactly. So it's a very, very serious thing. And as I say, by and large, half of it cannot be fixed. So once we are educated about it, we know what to do, when not to do certain things, when to do certain things, we can then help ourselves more or less. So I normally tell most of my patients when they come in with back pain, once I've gone through all the red flag symptoms and all the things to look out for, I would tell them in the future, if these pains are similar, you need to see an alternative practitioner. That is your physio, your acupuncture, your chiropractor, whatever. Because there's not a lot a doctor can do for back pain, to be honest, unless I will go through the red flag symptoms of back pain. So let us touch on the wear and tear aspect first, the simple one. So wear and tear back pain, yes, you will get lower back pain. It can occur at rest or if you do any overuse of your muscles. So patients who do prolonged standing or prolonged sitting. So anything that causes prolonged, inactivity at some point, usually in wear and tear you get that more when you are at rest. So you sit for long periods or you stand for a long period, you tend to have back pain. Most of these back pains, they are confined to the back and they don't radiate to the... Radiation means the pain can radiate around the buttocks and the area of the lower back.
People say the pain moving.
Yes, the pain moving. So when we talk about the pain, we talk about radiation of the pain.
Yes.
And classically, we know most pain radiation, in terms of back pain, with regards to back pain, comes from the nerve irritation.
Yes.
So, Rabbi, if you can put up one of the images of the back, and I just want to highlight something. I brought something here. I don't know if you can see that. Okay. So, yes. Okay, yeah, that's brilliant. So what we've got there, we've got the vertebra. So the white part where my thumb is on, that's the vertebra. So that's bone. The red bit is the intervertebral disc. So that's the cushion I talked about.
Right.
And below that again, you got another vertebra, right? So you get vertebra. And different parts of the back, they're called different things. Cervical, thoracic, and lumbar.
Right.
And the middle where the yellow bit is, that's the nerve passing through. So that's a canal. So the canal is at the back of the bone there.
Right.
The nerve passes through there. Now, what tends to happen? So when you squeeze, the second image, I squeeze the disc, and that is called a disc prolapse, bulging of the disc. So if you look at the end there, once you put pressure on that disc, it touches the nerve. And then you could see on the image on the right, where the red bulges, that's the disc bulging, and it touches the nerve. And that is what you will call neuropathic pains, and classically sciatica that patients complain of.
Right.
But you have lots of nerve, different parts of the body, different nerve supply, different parts. So the neck wouldn't give you sciatica. The sciatic nerve is from the lower part of the body.
Yes.
So the neck would give you cervical disc prolapse. It pinches the nerve and the neck. All right, so we're clear on that. So you have the disc, we have the vertebra, which is a bone, we have the disc, which is the bulging bit, and then you have the nerve. And the back is called the spinous processes. But where the nerve comes out, Robbie, if you take that off and just put my image, I want to just highlight something here. On this image, there's a nerve from the spinal cord. It comes out like a Christmas tree, for instance, right? And these nerves supply different parts of the body, the exit nerve. So this is called the exit nerve. And this canal where the nerve comes out meant to be smooth. And if you have wear and tear of the bone, you can have irritation of this exit nerve. Now, so two things you can get. You can get bulging disc, what irritates the nerve. That's when the disc bulges and it touches the nerve. Or you can have just the bony prominence at the end of the canal, these bone spikes. As the bone, you get wear and tear in the bone, you have spikes of bone, and they can irritate the nerve. So classically, what tends to happen, patients will come in and say, Doc, I've got back pain. Where the nerve exits, it radiates along that nerve. The nerve travels and it supplies a specific part of the body. And once you correspond that, okay, this disc is touching this nerve, and this nerve supply this part of the body, we can then conclusively say your pain or your numbness or your burning sensation is due to that nerve irritation. So that's your slip disc in summary.
Right. So I have a couple of questions here from our viewers. I don't know if you can see them here. Yeah.
So, first question, bad kidneys give you severe back pain. That is correct.
Yes.
So our kidneys are more at the back, more or less. They're not lots of things in between the back and the kidney, right? So it's more a posterior type of organ.
Yeah.
And it's in the upper back, in the,
I had kidney stones. So
correct. Just below the rib. Just below the lower rib of the back, right? So that's where your kidneys are. And
it radiates to cut to the front.
And then the tube that connects the kidney to the bladder is right up in front of the by your groin. So imagine you have a tube coming from the back of where your ribs are, this way.
Yeah.
Now you tend to have stone formation in the kidneys, generally, most of the time. And then it moves when the stone, depending on the size of the stone will travel down the kidney into the bladder and get stuck somewhere, depending on the size. And that gives you severe back pain. As a matter of fact, it causes excruciating pain. You told me you had similar symptoms. So you've got a double whammy. You've got back pain plus you've had your kidney pain causing back pain as well.
I had it all. Gita, I read your message here, and Lord, tonight topic is on nerving for me. Don't know if I will stick around too long. Would have loved to see how it goes. I lost my husband to collapsed spine. Still painful. Remember?
Sorry to hear.
Sorry, and that's why we're dealing with these subjects, so that people can know about these things. Yeah.
My heart, goes out.
Hang in there, man.
One of these things. Sometimes it's difficult. You become emotional when you hear these stories, and but. Coming back to where we're talking about
the back pain and
the kidney.
Yeah, kidney.
So kidney stone is a very common cause. So when we look, besides the structures of the back, we look at anything around there. So even if you have things like pancreatitis, the pancreas, you can have pain radiating to the back. But these pains generally would be mid-back.
Yeah.
So you have upper back, usually neck problems, mid-back, and lower back.
Right.
Yes, if the pain is, if the stones are in the urethra, that is a tube connecting the kidney to there,
Pain is going to travel down.
Pain is going to travel down, and then it moves to the groin and testicle area and things like that. The other question is, doctor, is arthritis common in the spine? The answer to that is yes, but not the type of arthritis that people would attribute to. So when we talk about arthritis means inflammation of the joint. And wear and tear arthritis is very common in the spine and the other joints of the body. But when we talk about inflammatory arthritis, that's a different type of arthritis where the area is inflamed. And usually that has got another cause generally. So when we talk about inflamed, it's red, it's swollen, it's hot. So when you have a joint that is red, swollen, hot, that is an inflammatory process. But when you have wear and tear type of arthritis, it's not inflamed as such. You have some degree of inflammation, but not to the extent when you have inflammatory arthritis. So that we call wear and tear arthritis. So the answer is yes, wear and tear arthritis is common in the spine. Now, what is spinal stenosis? So on that image I showed you that the spinal cord goes through a canal at the back of the vertebra. So there's a hole there that the spinal cord travels. So our brain, and then there's a cord goes down, and the nerve travels through that cord. Like let look at it like a circuit, like a wiring system. Oh, here's the image. Yeah. So the spinal cord is here. Now this canal that it comes through. Let me see what best way. So you see the canal. This is the canal. So that's a hole behind the vertebra, and it comes through there. Now, as you get arthritis, this canal meant to be smooth, and it doesn't affect the spine generally when you're young. As you get older, the canal gets rough and it tightens because you have wear and tear. And wear and tear of bone, as we know, you have spikes and little bits and bobs growing on the bone, and you have irritation. So the canal gets narrow, and that is called spinal stenosis.
Okay.
Now, the manifestation, of course, can be varied. It varies because all the nerve fibers. So it's like you have electric circuit wire coming down, and I'm squeezing that circuit. So wherever the fibers, there's pressure in the fibers, and these fibers supply different parts of the body. Some may supply your arm, some supply your leg, some supply different parts of the body. Your chest area, your abdominal area, it can cause different sensation, numbness, weakness. Now, just to give some clarity on how the body works, nerve generally from the brain processes information, it travels down the spinal cord in these electrical tracks, and then it goes to the muscle. So that's called a motor function. Motor function means the brain sends a signal to the muscle, and the muscle reacts. So it has to travel down the nerve. So from the brain, the signal, electrical signal, comes down the spinal cord, it goes to the muscle, and the muscle responds. So if I want to move my hand, we have to do that. So that's called a motor function. Now, if I touch something that is hot, a signal gets into the nerve endings on the hand, and it travels up the hand, and it goes to the spinal cord, and then it goes to the brain, and then the brain interprets it. So it's that's a whole process. So and that is called a sensory, the sensory part of the nerve. So you have a motor part and you have a sensory part. And then you have in the sensory part the fibers. They have different fibers of the nerve. Some test for pain, some test for temperature, some look at position. So if I put my arm somewhere, I would know if it's pain, if it's temperature, if it's position. And that's how the signal gets into the brain and is interpreted. So anything that touches the nerve, damages the spinal cord, you get that. I want to come back to, Gita's husband, the reference to a collapsed spine that can cause problem. Imagine your spine support your nerve, and if that spine collapses, It pinches. It bend the nerve. It pinches the nerve. So if you have a collapsed spine, the
length of the spine becomes shorter.
That's correct. It kinks.
Right.
So if the nerve kinks, what happens? It shuts down the electrical activity beyond that. So patients can get paralyzed. Totally. So depending, if you have, it's like you can transect the whole cord and you become paralyzed everything below that. If you have a kinking that transect the whole cord. If you have a little area that, okay, the nerve is thick and I just touch a couple of fibers, wherever those fibers supply, you have symptoms. And again, you can have motor symptoms, that is weakness in the response of the muscle. So that's when you can't squeeze, you can lose loss of power. And you get sensory symptom where you have heat problem, sensation problem, temperature, position sense. And as a matter of fact, it can present like a stroke. And I mean, unfortunately, we don't see collapse of the spine that often. We see it in important conditions that can be dangerous. One, if you have a big trauma, so you fracture and burst the spine, you can get that. And also you can have what we call pathologic fractures. That is, as the bone gets weaker, and this can come from osteoporosis, or if you have cancer of the bone, and the bone collapses without trauma. Minimal trauma or no trauma, remember the body weight is on the bone. So what tends to happen, this bone collapses like that and it bends the spine. It bends the spine and the spinal cord.
We have a couple of questions here. Does wear and tear arthritis only affect the back?
No. Wear and tear arthritis can affect any joint. Arthritis, any joint you can get that from. So wear and tear can affect the back, it can affect the knees, it can affect the hips. And your fingers, even people who do dexterity, do lots of job with their hands, they can have wear and tear of that. So wear and tear can affect any joint.
Can hemorrhoid cause low back pain?
Generally, yeah, it can, but you wouldn't. That would be what we will describe more like radiating pain. Remember, hemorrhoids is right down to the anus.
Right.
And if you have the anus is inflamed, of course you can get pain radiating around the whole buttocks. But it is not a common cause to say back pain. But if somebody were to get hemorrhoids with low back pain, we would want to check for other causes to make sure, fine, hemorrhoids, you get bleeding. You may just say, oh, this is simple hemorrhoids.
Right.
But you can have other conditions. You can have an abscess. You can have cancer as well.
Right.
And importantly, in back pain, I'll tell you about the red flags. Red flag in lower back pain. There's something mnemonic we use called tuna fish.
Tuna fish, okay.
So if you look at tuna fish and you remember that, TUNA, T is for trauma. So, okay, for simple back pain, mechanical back pain, so we're talking about back pain, no neurological signs, the pain is localized to just your back, usually it's chronic. And if you don't have any of these things I will list for you, tuna fish, T, trauma, U is unintentional weight loss. So patients can remember this. T for trauma, U for unintentional weight loss, and for neurological symptoms. So we talk neurological symptoms would be those pins and needles, sensation or motor problem. So if you got weakness, that's motor weakness or sensory problem. We're looking at red flags. Now neurology, TUN, N is neurology. Neurology doesn't have to be only weakness in the limbs. Remember, the nerve also supply our bowel and bladder.
Right.
And as a matter of fact, this is a red flag generally. If you have lower back pain and it affects continence, that is continence to urine or feces, you lose control of your bladder or your bowel, that's a medical emergency. You have to go to the emergency room immediately. We have to ensure that you don't have something called equina syndrome, where the nerve is trapped. And if those nerves are trapped for too long, it damages the nerve and you can permanently be incontinent.
Wow.
So anyone with lower back pain that has got loss of function of the bowel or the bladder, or they have, another thing we look for is what was called perianal numbness. So around your anus, your anal canal there, around there, you can't feel. And that is why when patients have back pain, sometimes you go to the doctor wants to put a finger up your bottom. So we put your finger up the bottom and you have to squeeze. So this is sphincter. We want to see if you have control of your sphincter. Because when you get incontinence, you don't have control, you just poo without control.
Yeah.
So one of the ways of testing if you trap the nerve that supply your bowel and the bladder, we put our finger in your anus and we tell you to squeeze your bum. And you test for the tone.
Right.
All right, so that's one. If you don't have that, medical emergency.
Yeah.
The second thing, and then we look for sensation. If you can feel me touching you around the anus. So that is a top red flag. Right, so we look at tuna, fish. So we cover T, trauma. I'll just repeat it. I want patients to remember this. T for trauma, U for unintentional weight loss, N for neurological signs, A, age over 50. And we do that because as you get older, you get more risk of cancer generally. Fish is fever. So we want to know if you have an infection, because if you have an infection in the bone, it's called osteomyelitis. That can be dangerous as well. Fish, FI, I is for IV drug users. They're prone to blood infection. So you can get infection in the bone again. S is for steroid. So steroid use. So there are some patients who have got, let's say, inflammatory arthritis, they're on steroids, or they have endocrine problem, they're on steroids. So steroid weakens the bone, and you can have collapse of the bone with minimal trauma or no trauma. So we want to make sure you're not on steroids. And H is for history of cancer. So if you've got a history of cancer, you can have cancer spreading to the bone. So chronic back pain, again, also, if you have those, that tuna fish mnemonic, you should see your doctor to exclude dangerous things. And of course, at the back of mind, we want to make sure you don't have Cauda-Equina syndrome. We want to make sure you don't have cancer of the spine and infection. Those are the common things.
Gita did say when you explained what happened today, how the spine collapses, she said that is exactly what happened.
Yeah,
she said in the comments, right? That's exactly what happened.
Yeah, sorry.
So let me give you some questions here. So we do that. Can osteoporosis cause back pain?
Yes, no. So osteoporosis is really not. It doesn't really cause pain necessarily, but if you have a complication with osteoporosis. So what is osteoporosis? The bone has got a density. So when you hold this bone here,
right.
It's solid, it got a density. So if you lose, this bone becomes spongy, it maintains its shape and form. It doesn't do any harm right now, but it gets soft. And if it collapses, or it can cause pain. So the answer, indirectly it can cause pain, but that's not one of the hallmark of osteoporosis. You tend to have weakened bone and the risk of fracture, so you could slip and you have minimal injury and you get severe problems with it.
Okay. Can an epidural cause my left side to have pain inclusive of my leg?
100%, yes, because I said the nerve comes down here, and what is the epidural? The epidural is a space. The dura mater covers the spine. So when we are given injection and we want to numb the area,
you go straight in between.
We go in between to inject that area. So if I give extra epidural, or we hit, let's say, too much of the nerve, we give too much or the wrong area, you can have complications where it affects the nerve for a longer period of time. You can have scarring of that particular nerve because the intention of the epidural. So when I come to treatment, so I will discuss treatment briefly, because we look at the time.
Right. Yes.
Treatment of lower back pain. So first, we talk about signs and symptoms. We talk about red flags. What are the things to look out for? And then we're going to talk about what are the treatments available to us. So if we say that the most common cause is wear and tear of the back. Now, there's nothing magical I can do about wear and tear. And ever so often I get patients come in 100 times for the same condition, and doctors, sometimes we don't spend enough time, and I cannot overemphasize that. I'm guilty of it, and I'm sure lots of doctors are guilty, that you're running you hurry in and you're not explaining to patient in detail that, you know what, your back pain is here to last.
Yeah.
I cannot cure you from your back pain.
Well, when you told me that the other day when I was at your office, you said this thing has no cure. Immediately I tell myself, I say, well, here, I can do two things about this now. I can learn to live with it, or I can learn, because I just have to live with it. I don't have a choice.
Yeah, and I want to say, when we talk about the psychological component of our health,
yeah,
and in the UK, I send patients in chronic pain management. You know where we send them? There's a special department now.
Yeah.
University College London, they have a department, a psychiatric department, psychotherapy for those patients with chronic pain.
Right.
And including back pain is a big cause for chronic pain. So you have chronic pain and you think, okay, fine, I'll see a doctor and I'll fix my chronic pain. Most of the time, it's not as easy as that. And as a matter of fact, chronic pain generally, no, it cannot be fixed as you're cured. What is important, if we understand that this pain is going to be there, we know the red flags, so we know when it is dangerous. So, and we know that, right, if psychologically we are prepared and a doctor explains to you that, you know what, you would have to live in harmony with this, maybe you would try to adjust your life.
Exactly.
You're not going to spend 5 hours doing the dishes. When you know I'm in pain, I'll tell you, hey, your body tells you when you have had enough. And if I'm spending 4 hours washing the dishes and I start getting pain, my body's telling me, hey, you're overdoing it. So let me just adjust my lifestyle.
Let me tell you this. I'm as fit as I feel like I'm in my 20s.
Yeah.
Because I'm doing a lot of workout. I try to eat properly and all that. But doc, this might sound like an urban question. Does a big tummy cause back pain?
Again, yes, the answer to that is yes. So I explained in the beginning, you have your muscle trying to hold your spine erect. If I am putting pressure on that muscle by being overweight,
yes,
by adopting the wrong posture. So the simple things in back pain we want to do. We want to strengthen your muscles. So when we talk about mechanical back pain, this is your wear and tear back pain. This is your musculoskeletal pain, that there's nothing dangerous about this pain. But these patients, half of the population will suffer with that type of pain. And there's nothing, there's no nerve involvement. There's no weakness in their leg. They have control of the bowel and bladder. Now, they haven't had an injury and they don't have all the other red flags we talk about. How do we manage those back pain? The first thing I send them for, physiotherapy. Yes. How do I strengthen your back? How do I advise you that when you bend to pick something up, you bend and you bend your knees, maintain your alignment?
Yes.
If your posture is bad, you lifting a weight all the time and you're crouching, the symmetry of your body, the one muscle is under strain more than the other. So you want to maintain those symmetry, you want to strengthen those muscles, and it adds to it. If your tummy is big or you're obese, you're putting pressure on the spine. So, of course, the answer to that is yes, it will cause back pain.
Yeah. Treatment.
So the first treatment would be our lifestyle treatment I talked about. So I want you to maintain posture, strengthen the muscles of the back, and then there are non-pharmacologic treatment. So acupuncture is probably the best alternative treatment that has been evident, that there's some evidence for. Acupuncture helps chronic back pain. Chiropractor, so patients see chiropractor, they have massages and manipulation of the spine. So those are your non-pharmacological management. Now, we are talking here, as I say, mechanical back pain, there's no red flag symptoms, right? So we're looking to manage your pain so you can get on with your daily activities and your job and whatever you have to do. Now, let us come on to pain. What am I going to give you for pain? So we start always, in pain management, we have what is called a ladder, pain ladder, medication ladder. So you start at the lowest and you climb the ladder as the pain increases in intensity. So you would start with the traditional painkillers, your Tylenol and your ibuprofen and your, those anti-inflammatory medication. And then we will go a little bit stronger than that. We will start with mild opiate type drug. So your codeine-based drugs, tramadol as you go up. And then, of course, you can go to your real strong morphine type of drug. Like
Pethidine.
Fentanyl patches. We'll give...
No, Pethidine?
Yeah, Pethidine is one of them. Yeah. But Pethidine is more for acute.
Okay.
I wouldn't give you that for chronic pain. Now, the problem is I wouldn't give morphine-based product. I would give the milder morphine-based product for milder opiates for chronic pain because it's an addictive drug. So if I anticipate that your pain is going to be forever. I'm not going to start you on those drugs right away. Is when I've exploited everything, I've explored everything, and I don't have any option, that's will be last resort. And also we reserve that for patients who have got the type of pain that I can't fix and they're terminal and they're, like...
This is a last resort?
This is a last resort.
Okay.
So then I can say, fine, I don't mind you get addicted because your lifespan is shortened and I want you comfortable. That's my, my intention is to make you comfortable, pain-free, and we can do that. So you have to know your type of patient, who you're going to give those opiates to. And I want to caution that, when patients, sometimes again, as professionals, we sometimes don't spend time to explain pain, medication enough. Because if you take those opiates type of pain medication, they are addictive. And a patient can come back and say, Doc, you haven't explained that this thing is going to be addictive, and I get stuck in it and I can't come off of it. Secondly, you mentioned to me that the pain tablet made you a bit drowsy.
Right.
So that's a very important thing to explain to patient. If I'm giving you pain medication and you get drowsy and you get into an accident while driving, I'm responsible.
Right.
If I haven't explained the side effects.
Yeah.
And we have, let's see if this is a patient. Hello?
Sure?
Yes,
Yes, it is.
Yes, I know you from this radio. Now, there's one thing that I'm listening to the program. It's very interesting.
Thank you.
I don't think that I heard anything about body mechanics.
Yeah.
Like in lifting, if you lift improperly, you're going to get
Absolutely.
injured.
Yeah, I think you just mentioned, you just mentioned about lifting.
I talk about posture and your body. Yeah, when you lift something, you bend your knees to lift rather than bending your back like that. When you also bend, remember when you bend your spine, you open the intervertebral disc, right? And if you were to, the pressure that goes down there, if you were to cough or sneeze while you're doing that, you can pop a disc. And that's something patients have to, be aware of that when I am now making a position where I am opening the disc and then I put pressure by coughing or sneezing, I can have a disc bulge. So yes, thank you for, highlighting that. And it is without a doubt a very important aspect of the management. How do we do, body mechanics? And when I refer patients to the physiotherapist generally, part of their remit is to go through that. Of course, they are more trained in that aspect than I am. So, thank you for that.
But most people, the problem is once they have a problem with their back, they skate to have a doctor do this and them and do that and them because of false news.
Yeah, but most people, including me, many times I don't want to go to the doctor with my back pain because I'm thinking that if I go to the doctor, they're going to want to do some surgery. I may never walk again. I may become paralyzed. And that's he's right. A lot of people scared.
You're spot on. But I would say this. of all my patients with back pain, of all the conditions that I've seen, back pain management in terms of majority, I've heard patients, they get in 5-10 injections every week just for their back pain. In my part of the world, we don't do that.
Yeah, but it depends on what injection.
Right, that's what I was going to explain.
2 injections that are on the nerve root.
Right, so let me clarify. So what I want to clarify there, that's the point I want to make. So when we escalate treatment, there's a place for nerve blockage, where you give injection or you can do something called radiofrequency ablation. But you've seen, lots of patients over the years who would say, I have had 5 injections in my hip for this pain. At every week I go for an injection. And that is not a best practice in my opinion.
Right.
Best practice would not do that. When we give nerve injections, they're done under a fluoroscopy, they're done under guidance, so we hit the exact spot. And you don't do that you know, you
Because
don't.
I went to it, you see, and actually I had 2 injections with 2 close, and I ended up with a vascular necrosis.
Yes.
Where I had to have the both hips, they deteriorated. And I had to have,
that is why I want to caution patients on not having, because what tends to happen sometimes, patients go to the doctor for injections because they say the pain is there, and they get things like steroid injections, painkiller injections, but you really want to do the least intervention. Intervention has got its place. So when I go, let me go through the treatment ladder. So I will come back. So thank you for raising those points, but I just want to go through the treatment ladder as to what options we have.
We have about 3 minutes.
Pros and cons of
2 minutes.
it.
We have 2 minutes to wrap up that.
All right, take care. Thank you.
Yeah, thank you very much, sir.
You're welcome. All right,
Yeah.
So, okay, I want to highlight this, and I want to get this clear.
Yeah.
So I talk about our mechanical pain. So you come in with your low back pain. There's nothing dangerous. What I will possibly do, an MRI is only indicated if I have signs that you have trapped a nerve. What does the MRI give me extra? It gives me the soft tissue aspect of it. If I want to know about your bones, MRI is not the best modality of investigation. Your X-ray can give me enough information about the bone, unless I'm looking for other things like, even, early stages of cancer, then of course I can have other, CT scan and things like that. But your standard wear and tear, an X-ray is good enough.
Okay.
If patients have got signs of nerve involvement, then yes, an MRI will be it. It's only when MRI contraindicated, I do CT scan. So that's another thing I would want to highlight. CT scan of the back is not a common modality of investigation, unless we are looking for other surrounding structures. But if I'm looking purely at your spine and your spinal cord, if I'm looking at the bone, an X-ray will suffice. If I'm looking at nerve involvement, then an MRI will be the deal. If I want to know if you have organ involvement extending beyond patients with history of cancer, for instance, then yes, a CT would be appropriate. So if I start you on your body mechanics and your acupuncture and your physio, your pharmacologic, then I go to pharmacologic, your pain management. If that fails, simple pain management first. So we haven't reached morphine base, so I'm not going to go down that route. Usually I resort that even before this drug that I'm going to tell you about. There's a set of drug called neuropathic agent.
Okay.
So when we talk about back pain causing irritation of your nerve, we want to give you drugs that desensitize the nerve. So tablets. So there are drugs like amitriptyline. They work on the nerve. Pregabalin, gabapentin, duloxetine. These are the type of drugs that we can give patients who have got neuropathic pains. So they have the back pain that radiates to the leg, and they have pins and needles, they have burning sensation. These are the drugs I will give even before I give opiates, that is morphine-based product, right? And then if those patients are now responding, I wouldn't even go to any of those strong painkillers as yet. I will send them, once we have identified that the nerve that is involved, we do the MRI, and we know, okay, this nerve is involved, then we can send you for injection. Now, the injection is a mixture generally of anesthetic with steroids sometimes, and it's to take away the inflammation around that area of the nerve. And of course, that is done under guidance, and you go to the exact point and you inject those drugs in there. And that's in the injection this gentleman was talking about. But what I was alluding to, patients getting many injections, they will get injection in the buttocks for pain in the lower back, for instance.
Right.
That is either painkiller or steroids or something, but I don't know. You can have injection at the point of tenderness. So sometimes you have pain in the gluteal area, where, like in the bum where you're sitting on at that point.
Right.
You can inject that again on the localized area. You can have injection at the side of your hip. If you take your hand and you stand straight and you press the side where your palm is,
Right.
that area can be tender. That's called trochanteric bursitis.
Yes.
So there is a bursa, which is a fluid-filled cavity, can get inflamed, and you get that pain right there.
Yeah.
So we can inject some steroids in there with local anesthetic. So those are the kind of injection I would advocate. but not regular injections every week for prolonged periods, because they're not usually helpful. And then the next option would be what we call radiofrequency ablation. So they can put like a heat, a radiofrequency wave, create heat where they burn the nerve.
Okay.
So we have nerve that supply the sensory nerve, the pain nerve. They just burn those fibers. So you take away the pain. And then the last resort would be surgery. So spinal stenosis, of course, there's a place for surgery. If I got a nerve that is trapped and I need to release that nerve, there's no tablet going to fix that.
You got to go in.
You got to cut that, open it, and do. And they have different procedures, laminectomy and microdiscectomy, and, release that nerve. So there are different surgical procedures. So there's a place for surgery. But, of course, surgery of the spine is delicate, and you want to be convinced totally that this is my last resort. Then, I'll send patients. And, of course, I would leave that. That's out of my remit. Neurosurgeon or spinal surgeon would be the guy who would be my next call. If I feel that my patient is not getting better, or even if I give them all these, medication and they have neurological symptoms, they need to see a neurosurgeon.
Yeah, well, Doc, we're going to close up here tonight. Viewers, thank you so much for joining. Thank you for the questions. I hope we were able to deal with all the questions tonight. So next week we're going to be back here again on Tuesday at 8 p.m. I know that a lot of you're supporting the Warriors out there. I went to one of the games. It was Sunday night. I went, and it was fun. I enjoyed the game. I think that's the only one for this season for me. But again, while I was driving coming here this evening, there was a trailer in front of me with no light at the back, and just traveling through, two other guys bracing people off the road. Again, just be careful on the roadways. Watch out for those who are not watching out for you. And as I always say, stay healthy. And Doc, what do you want to say to our public?
No, I don't think I've done enough justice on this back pain stuff, because it's a big one, so we can manage that back, and also arthritis in general. I want to talk a little bit more.
We can pick it up next week.
We'll pick up next week. Definitely. Yeah. But thank you all for watching, and let the questions come in, and I'll be more than happy to answer whatever I can.
All right, good. Yeah. All right. Good.
Thank you so much.
Thanks so much for joining us. Stay healthy.
Thank you.